I'm tired of, giving up the imaging to someone who's not going to do I don't think a very thorough and, comprehensive and compassionate
Right.
examination. And so I'm going to keep it in my office.
Dr. Weston, thank you for joining us today. Could you just tell the audience a little bit about your practice, the types of patients that you see? I'm assuming based on our previous conversations, you're not just a liver guy.
That's correct. I see the entire gamut of gastroenterology, hepatology. Don't turn anybody away. But a big part of my practice, since I got involved with liver disease when I was at the VA, it was a very important priority at the VA, hepatitis C eradication back then. And now, jump forward 20 years, and the big elephant in the room is fatty liver disease and NAFTL and cirrhosis. So that's a big part of my practice today.
All right. So you've been in this specialty for over 25 years. Can you tell me about the progression of the different diagnostic methods you've used throughout the years and your experience with the different ones?
Yes, in fact, 30 years ago, fatty liver was, diagnosed by an ultrasound, and there was a very prominent journal that said, fatty liver is a benign disease, you don't have to worry about it. And at that time, 30 years ago, we didn't worry about it. It was just something you just sort of ignored. But now it's a huge part of it's a huge economic and medical burden, and it's a serious disease. It's a leading cause of liver failure in the United States right now.
Yeah.
So 30 years ago, we didn't have ultrasound anything. We just had an ultrasound saying fatty liver, and then we developed these serologic tests, which I never was a big fan of. And I think the best one now is called the FIB4 score. It's very simple, looks at a patient's age and their simple liver tests, AST and ALT and platelet count. But there's a whole bunch of proprietary labs that have these so-called accurate staging of a patient's steatosis severity and fibrosis severity. And I used to order those, 15 years ago, and I stopped ordering those 10 years ago or 7 years ago when I incorporated, in-office ultrasonography with elastography. I've totally stopped ordering these fancy lab tests.
Did you see a limitation with the tests, or what was the reason that you wanted to stop using them or felt that you could?
I just didn't. A lot of me just didn't trust. You had patients that, you clinically said, man, this person has got some serious liver disease. And you'd send away this, Fibroscan score, and it'd say, oh, they don't have any advanced scarring or advanced steatosis. Don't worry about them. And you're going, holy, the patient's in front of you.
Yeah.
And you're saying there's a disconnect.
I see.
And some of these proprietary tests that LabCorp and Quest and other people have, they're a little pricey, and some of them they're skewed. If there can be skewed by a certain lab test that can be erroneously off for a different reason, gives it a false reading.
I see. So you mentioned just a second ago that you incorporated ultrasound into your practice about 7 years ago. That makes you both a pioneer and an expert in your field for ultrasound. What was there a compelling what was the compelling reason for you to do it versus sending it off to, let's say, a radiologist? Because by and large, would you say that's kind of the norm in your field, is to refer the patient out to imaging?
It has been, and initially we did that, but there's no patient doctor interaction. If the patient's in your clinic, you've connected with the patient. It's a doctor-patient relationship. When you send to the radiologist, the technician does it, and They don't talk to the patient. You know, a radiologist reads it in a dark room, doesn't even, you know, never sees the patient. And I got very frustrated, you know, I'm in my community where we'd have, and this is this true story, we had patients that were getting ultrasounds done and they were coming back, you know, limited examination of the liver, you know, cannot find the liver, cannot find the gallbladder, you know, cannot find the portal vein. And it's just like, oh my gosh, I mean, and so you just wanted to, and you want to give your patient an answer.
Right.
And so I just said, let's, you know, I'm tired of, you know, giving up the imaging to someone who's not going to do I don't think a very thorough and, you know, comprehensive and compassionate
Right.
examination. And so I'm going to bring it to keep it in my office and give a patient, you know, a real time, you know, answer.
Okay, so I've got a lot of questions surrounding that. One of the things I hear from some of your colleagues and peers is they're not trained in ultrasound. How did you add it to your practice when, like, what was your training like? Did you have any, or did you learn it from YouTube, for instance?
That's a good.
YouTube wasn't around probably, but.
That's right. It wasn't, and it was a multi-pronged. You know, I was trained at the university in endoscopic ultrasound by a radiologist in the 90s. And so I think any gastrologist that does endoscopic ultrasound with a scope, incorporating in-office ultrasound with a transabdominal ultrasound probe is seamless. There's no issues.
So describe the technology. A lot of some discussions that I have, it seems there's a little bit of a misunderstanding when you say ultrasound versus transient elastography, or, you know, some people refer to it by a brand name, you know, Fibroscan, right, is what they call it, but it's transient elastography. What is the ultrasound technology? Can it replace the transient elastography that a lot of people talk about? Is it a complementary tool? Tell me about the technology, if you don't mind, and how you use it.
It's you know, transabdominal ultrasound, you know, is superior to, you know, vibration elastography is just vibrating the liver. You're vibrating the liver. That's why the patient feels a little thump every time you fire the probe. So it vibrates the liver and it sends back a signal, and you capture the signal, and you get this, you know, magical score saying, you know, this is how stiff the liver is, and you get another magical score that says how much fat the liver has.
Right.
And the problem is you know, you're not really seeing exactly what you're firing it into. You don't have an image of an actual liver organ in front of you. Whereas the transabdominal ultrasound, you know, you can see the liver, you can avoid vascular structures, you can avoid the gallbladder, you can avoid intervening colon, intervening lung. And so you can make sure your ultrasound probe is exactly on the liver. And this is a great deal of my number of referrals. I get a lot of patients referred to me, Paul, that there's new patients for, you know, abnormal imaging. That is, they got an imaging from another facility or another doctor saying fatty liver or, you know, nodular liver. And I tell patients is that I tell them, well, why? And they ask me, why are you repeating the ultrasound in your office? And I say, well, we got an ultrasound that has special software. And I tell my patients, it's like, you know, you got an ultrasound done by, you know, the guy that sells Yugos, or, you know, a Yugo, you got a Yugo ultrasound, which is, and, you know, we're gonna give you the Rolls Royce ultrasound today. That's got a lot of. I mean, yeah, I do use those terms for my patients so they understand. You know, I'm not here to, you know, why am I doing this ultrasound? But we did tell them, you know, it's very, very, you know, advanced software, and it can see things that other ultrasounds can't see.
Yeah. So you mentioned the vibration controlled transient elastography, or VCTE. The ultrasound uses something called 2D shear wave elastography. And does it give you, do you feel confident with the quantitative output you get from your ultrasound system versus the VCTE equipment?
Yeah, we sure do, because you can trust when you're actually seeing the liver live in front of you, and you're on top of the liver. And I think what's the beauty of it is, I've been blessed that I bought your first generation, shear wave elastography machine called Supersonic, and now I'm honored to be one, to buy the newest edition. And the newest edition is just incredible.
Yeah.
It's a game changer. And
Awesome.
but as far as one thing we get with the Transient, they don't like to talk about this, but sometimes you put the probe on the patient and you fire it 10 times and you get 10 readings that are within their special standard deviation, and you can accept it. But I have some patients, you fire the probe 50 times. 50 times. Yeah, this vibration probe, and you vibrate them 50 times, and you get a reading that's, quote, acceptable only after you've thrown out about 30 values. You know what I'm saying?
Yeah.
And so it's really concerning to me that you've got a machine and you're throwing out values that were, quote, adequate, but in order to meet their guidelines of getting their quartile is at 30%, that you have to throw out all these values. And the beauty of the supersonic shear wave is that you put the Q box on it, you put the elastography on the liver, you get a Q box, and if it doesn't say 90% or greater, you don't accept it. You don't even take a picture of it. So you only get an image, and you want to, and in fact, we're getting 100% with the new machine. We're getting the image is so incredible that we're getting 100%.
Confidence interval.
Confidence. Yeah, thank you, Paul. Yeah, confidence. I never seen that. I had never seen 100%. We've had 99s with the older machine, but we always get above 90. But this new machine is, 98, 99, 100s. It's just, it's quick.
Awesome.
That's the other thing with the transient vibration is, we might see 15 patients, for doing transient vibration. And if you have to shoot them, if you have to fire the probe 50 times for each patient, that adds up. It's not, and it puts you behind clinic.
You are probably one of the few guys that does it in their office, and versus having them go to the radiology, to the hospital, which probably, I'm assuming, costs them more money out of pocket than them just having you do it because you have the technology. What sort of reactions do you get from patients, if any?
Patients are so grateful.
Yeah.
A lot of patients come to your office and they're nervous. Doctor, do I have fatty liver? Yes or no? Do I have severe fatty liver? Yes or no? And do I have cirrhosis? Yes or no? And when they can leave your office and you can answer, no, you don't have to worry about it, they are tremendously relieved.
Sure. Yeah.
Or likewise, just on Monday or Tuesday, we had a patient that we found out that she was referred for, fatty liver, that she did have severe fatty liver, but she didn't have any advanced fibrosis. And that in itself was a relief. And then it's a game changer for her because now, and we told her, if you lose weight, you exercise, you eat right, take vitamin E. And so now she's leaving her office with a tremendous confidence that it's not too late, and then she can intervene and make a change in her life.
That's awesome.
You don't get that if you send it out somewhere else.